Good morning. Welcome to the Harvard Faculty Club. It is my great pleasure to welcome to the Symposium for Integrated Health, Dr. Sharma, the CEO of Sovereign Health. If we can give him a round of applause.
Good morning, everybody. Apologies for JetBlue and their flight disruptions. But they finally got me here. So I know we are a diverse lot of people. Some of us are physicians, either by training or working as physicians. Others are from a different background. I'm hoping that this will come into integrated health because this topic has got far-reaching ramifications. It affects almost all the specialties. And since this is what we do, behavioral health, and that's my specialty, I thought I'd talk a little bit about it. I'm hoping to go on for about 20 minutes and or slightly longer. And if you have any questions, be happy to answer them. So the statistics, you see those on CNN, you don't see that on Fox News though. You would see that in the mainstream media in terms of how many people and how many lives are lost. It's the biggest uptake of all this is in the ERs, in the accident and emergency departments. And people don't realize that they're being deluged by the excess in terms of the excess of people that come in. We think that somehow these people that suffer from opioid problems go into specialist units. No, they are putting a lot of pressure in the general healthcare system. And I have a slide about this later on, but let me talk to you about it now. The media's portrayal of the tattooed person injecting themselves is way old. We see people that are in jobs, that are doing well, that are living with addiction. They may have had an injury, and now they have to have their opioids, or feel that they cannot get off their opioids. We had an instance where we had a real estate agent who was obviously showing houses and taking opioids from the people that he was showing houses, those particular houses. So my point is, this is a middle class problem now. These are problem of professionals. This is not the typical so-called addict or somebody suffering from addiction that we have seen in the past. So, and then this is a social plague. Why? And if you look at it, it's the synthetics that cause a lot of problems. We see this frequently, and our adolescent facility in San Diego sees an equal number of problems. And we have our general physicians at our facilities have to deal with multi-system problems. It's not, the addiction is a brain disease piece, we'll talk about it, but it's all the ramifications around that for physical health that cause all these issues. Opioid orphans, we have heard of them, and how this epidemic is destroying communities around the country. So what are we doing? Well, we know that the combination of both behavioral therapy or talk therapy as well as medication is the ideal combination, and the National Institute of Drug Abuse as well as SAMHSA have talked about what are the best evidence-based treatment. The problem in this industry has been severalfold. One is people have come into the addiction space from personal recovery a lot of the time. Well, I got sober or I got clean, so I know how to do this. And my point is, and somehow they also think that somebody needs to be in recovery to be able to talk about addiction. And my analogy is, do you need to have a heart attack to be a cardiologist? So, and it's as ridiculous as that. somehow, in about 2009, when we started off in San Clemente, we were ostracized because you're not part of the recovery community. And that's my analogy in terms of saying you're experts, you need to be experts in treating the illness itself. The other thing is mainstream medicine has somehow either shunned or not been incorporated into treatment. And that is why the medication-assisted treatment, which should be the normal thing, it's like insulin or metformin for diabetes, that you're taking medication for your illness, that has been delayed severely. And even today, about 60 to 70% of the current treatment facilities in the US do not use medication-assisted treatment. Somehow you have to get clean and sober by abstinence, and that is it. So theoretical and cultural, moral, as well as sometimes religious underpinnings cause problems in terms of delivering the quality care that you want to do. So we come to measurement-based care. And I put that up because the industry of addiction treatment desperately needs standards. We know that within so many minutes, you need to have a blood, after having a stroke, you should have, only within so many minutes should you be given an anticoagulant. After that, there's a protocol. After that, there will be a problem. And that's the accepted treatment. Now, what is the accepted treatment in substance use disorders? And this is what we've been trying to do. So, and you're aware of this, there are high-profile cases in many places where somebody who has been running a Papa John's franchise opens up an addiction treatment center, because in some states it's pretty easy. They wouldn't think of opening an urgent care, but opening a rehab is not a problem. Why? Because, well, I got clean and sober, I know what to do. They would pay consultants to get a license, they would hire therapists, but they would enforce their own belief systems into treatment. The problem is they are not people who come from a treatment background or have the knowledge base. And that's why you see all these strange things happening. So coming to measurement-based care, it's an attempt, and I've been talking about this for a while, it's an attempt to have some evidence-based treatment that is accepted by both academia as well as the federal institutions like NIDA, the National Institute of Drug Abuse, as well as SAMHSA, so that we can have some standards. So if you are going to send your friend to treatment, if you're going to send your relative to treatment, you need to know that these people that are treating your loved one are following certain standards. So these are the components of measurement-based care. The treatment, what is your treatment target? How do you monitor outcomes? And what are the feedback systems? This is quite normal for the rest of medicine. However, we are coming in the addiction field. This is something that we are increasingly talking about and hoping that we will be able to get to that area in that Venn diagram where we have these evidence-based medicine. Here you have the physicians or the therapist's personal opinion, or one of my patients were helped like this. Here you have this double-blind studies that do not have any are not real-life studies. This is for sometimes the studies that are required by the FDA, and these are patient preferences. So this is the part of the Venn diagram that we are interested in terms of evidence-based studies or evidence-based treatment. So why measurement-based care? Measurement-based care is really important in any field, especially so in substance use disorders, because it gives us insights into treatment. It helps us define what is the target of treatment. It also helps us modulate treatment. If somebody is improving or not improving, we should be able to measure that, modulate treatment, and then make sure that things are addressed accordingly. So clinical decision making is one of these things. The involvement of an active, informed patient. So what we are saying is bring the patient into treatment. Stop telling them that this is best for you. So continuous feedback loop. As I said, measurement-based care works in all sorts of medical settings. And so I often give the example of diabetes. I have a family history of diabetes, and so it's an illness fairly close to me. And the example is this, that if you go to your family practitioner, you tell him or her that you are dizzy and you have fainted a few times, and your family practitioner listens to you very, very empathically and then gives you some tablets for high blood pressure and hypertension. Would you take them if he or she never even measured your blood pressure? The analogy in the treatment of addiction and substance use disorders is exactly that. They take a detailed history, what is known as a biopsychosocial. Based on that, and this is a brain disease, everybody agrees to that now. So, and based on that, they will define treatment. The treatment of this brain disease called addiction or substance use disorders is completely brainless at the moment, because we do not measure the core and enduring problem, which is cognitive function and brain function. So you will not take your hypertension tablets if your blood pressure is not been measured. How do you even know that there is a problem? So what has happened is this kind of blunderbuss approach. Take the history, put them in a group, and they should be clean and sober for 30 days, 90 days, whatever it is. There is no system. And this is how treatment is carried out. That's why we fail so badly, and that's why the relapse rates are so high. So what do we do? You measure symptoms, you measure functioning and satisfaction with life, you measure readiness to change. Whether you want to give up smoking or you want to lose weight, the readiness to change scale is really very, very useful, so that we can see, where we are in that stage. And then session feedback and a therapeutic alliance. We measure the therapeutic alliance. What you can't measure, you cannot change or improve. So if you adopt that mantra that you need to measure to be able to change, there are a lot of easy instruments that are available, and you don't have to pay for them. And we developed a piece of software that incorporates all of these, so that our therapists can measure symptoms and then modulate treatment based on the results of these scales. A patient's ability to function and satisfaction with life is really important, and so we assess all of that. What is the addiction severity index as well for addiction? The quality of life piece we've incorporated in there. And I'm happy to send the slides to you. Just let me know. I'm sure we'll form some sort of email group that we can talk. Please feel free to take photographs, but I'll send it to you if you want. Readiness to change. Are we ready to change? And I think this is really important for all of us. As you can see, you've got several stages: pre-contemplation, contemplation, action, and maintenance. These are changes. In any change that we want to bring about in our lives, this is something that we've got to recognize and have insight into. For people with substance use disorders, it is whether they're ready to change, to be sober, and to be clean of their issues. So we have a questionnaire that tells us where are they in that system, and in that readiness to change system. So, and it takes less than a minute to administer. The question is, you could make it really, really academic. I know we are at Harvard, and that's an important piece, but we could make it really academic, and it could take 5 hours to assess somebody. That is impractical in high volume clinical settings. You want something that is valid, you want something that is easy to administer, you want something that doesn't require a PhD or an MD to administer, and preferably automated, and something that is quick. So there's a balance between the validity, the reliability, as well as the speed of administration. So if you have somebody with depression, if they are doing the PHQ scale and you find that there is no improvement, it's not the therapist's gut feeling that I think Johnny is improving. It doesn't matter. Here are objective scales that says Johnny is not improving. It doesn't mean you're a bad therapist. It could be that Johnny just needs a higher level of care or his medication needs tweaking. So our teams sit down and say, why is there no change, or why are there changes in the wrong direction or in the right direction? So, and then lastly, we measure the working alliance. The therapeutic alliance is very important, more so in the behavioral health industry and specialties, but in everything from general practice to surgery. One would have thought, I was doing surgery at one point, and you thought, okay, most of the time the people are asleep, so you don't need to have good bedside manners. It's interesting. The recovery rate in surgery is highly correlated, it doesn't mean there's a causation, to the therapeutic alliance built with the surgeon. So it shows that you can, if you have a good therapeutic alliance, you have good outcome. And so there are scales in which you, again, the scales are there, you can use them to measure the therapeutic alliance in any of the specialties that you are in. And I think that measurement-based care has got a central place in what we do. It's the way to use evidence-based care, and that has been sort of the buzzword for a long time. The question is, are you measuring progress in what you're doing? Are you measuring the symptomatology of the person? Where is your baseline? And then from that baseline, are you changing things around that will tell us whether things are, the patient is improving or not. And so, you can look at internal assessments, and you can also see how well you're doing. And the outcome measures are important. You can use that for the business development. You can talk about how good you are, your clinic is, etc. And then these are the other benefits of measurement-based care in terms of reducing relapse, looking at how we can, assessment of suicide risk, impending relapse, etc. However, here is the bad news. Only 11% of psychologists and 18% of psychiatrists had used measurement-based care. And this was about 3 or 4 years ago. And so this is something that we are pushing hard, and I think that as it comes into the mainstream and people see that not just centers of excellence, but you also need to have this in every single private practice, because you can then measure where your patient was or client was when they came in and what they're doing now. So why would we accept subpar treatment for any other medical condition? You would not. You want to look at what your surgeon is like if you're going in to remove your gallbladder. Why aren't we doing that with the substance use disorder industry? The issue is there is resistance in terms of being trained, and it's very simple, so there isn't a huge amount of training. These scales are all available. As I said, we have software we are making available free of cost to people who want to use it. And then here is the summary, that this is scientifically based care that is the way that we should progress in terms of treatment of addiction. This should be the standard of care, and there are several clinical scales that are there that will help us do that. So we mentioned the medical entities, whether it's the American Society of Addiction Medicine, whether it's NIDA or SAMHSA, all of them have said that this is what we should be doing. Measurement-based care, everybody says this is a brain disease, but we are not giving it the respect it deserves. In the meantime, we have the crisis in terms of overdoses and addiction. So here, and this is what I was mentioning earlier, that the portrayal that we've had in the media was quite different. We have people that are high functioning that are still addicted. I think that as we remove the stigma surrounding this illness, we would be able to treat more people. And then this is a quote from our former US Surgeon General, and he talks about why it is important for all of us to accept the fact that just like hypertension and diabetes, people suffer from addiction, sometimes not because they decided to use something, it's because something was prescribed to them and it was never tapered off. So I don't know whether I'm within my time, but I'm happy to take any questions, and I'll be happy to send you the slides. Thank you. There you go.
Excellent presentation. Absolutely excellent. I'm curious though, you made it specific to the opioid crisis, which is clearly a global problem. What and how does this apply to alcohol or other substances?
Oh, yeah, thank you. It's exactly the same. In fact, I put the opioid crisis because this is, the whole country and the media go through phases. More people die of alcohol than opioids. Yet we don't hear of alcohol as the problem. I had given a talk a few days ago about how alcohol is the #1 killer, way above opioids. But when you're giving a talk, you're talking about things that are more current. The same principles apply to alcohol. I use the opioids as an example, but I'm talking really about the entire spectrum of substance use disorders. And also behavioral health, whether it's depression, anxiety, PTSD, the whole eating disorders. You've got to see, are they ready to change? And where are they in that scale? And what can you use that's evidence-based? It doesn't mean that it has to be hardcore biological. We have equine therapy that we use. We have yoga, we have meditation, mindfulness, all of that. And even though the insurance companies say these are all experimental, we feel that having a holistic treatment module as such would be very helpful. However, you need to use your cognitive behavior therapy, dialectical behavior, CBT, DBT, all the things that are there in the psychotherapies, we've got to use. And also, whether you use Suboxone, Vivitrol, all the medications that are there. It's, again, I go back to diabetes. It's not enough to give somebody metformin as a tablet or insulin. If they will continue to gain weight, eat sugar, will not consult a dietitian, all of those are the ancillary things that happen. And we keep forgetting, we think, okay, just going to the doctor is it. It is not. You have to change your lifestyle. You have to have the rest of it. So it's the same analogy that I find in the substance use disorder field, that you need to, acute treatment is like being in ICU, residential treatment and getting detox, etc. Treatment starts after you leave rehab, so to speak. That's when it starts. And the insurance companies, unfortunately, and 99% of our work is with insurance companies, they do not reimburse in the substance use disorder field after people leave. But they do that for surgery, they do it for COPD, Parkinson's, heart disease. And I think educating them and telling them that this is a chronic, relapsing and remitting illness, and we need to maintain people in the community, not in treatment centers. I think that's the difference. But in answer to your question, alcohol trumps everything.
Thank you. Good morning. Everything that I've read about addiction talks about it as being a consequence of something community related. You just mentioned the importance of the community in this. Yeah. And so when I think of addiction, I always think of, well, gee, is there a way that we could prevent people from getting to that point of desperation where they feel like they need to check out? So we all, for a lot of other diseases, we talk about how we treat them. We talk about preventative care, but could there be such a thing as preventative care when it comes to addiction? And what would that look like if we were to think about it just like any other disease, like diabetes or hypertension or whatever?
Well, good question. There are several pathways into the addiction field. It could be, there is the sort of prescribed opioid pathway, if you like. And so somebody was injured at work, started taking oxycodone and continued doing that. I think with the new restrictions that are there in terms of prescription and the monitoring of prescriptions, it has people that should be getting such medication. Opioids are a godsend, because if you're in pain and you have, those of you that deal with pain, you would find that it works miraculously. The question is, when does use go into abuse? When does, and how can we taper people off? Because if you don't have that in your armamentarium and you are working with people with pain, whether it's from surgery onwards, question then arises as to how are you going to treat these people? You're throwing that baby out with the bathwater at that point and saying, okay, just ban everything, it doesn't matter. The issue is, and drug-free partnership for kids, and they just call themselves drug-free now, partnership, you'll see their ads on TV, they're telling people, the evidence that has been there, that if young people feel connected, then they are much less likely to be abusing drugs because they're trying to find something that is missing in their lives. They talk about having dinner as a family, and that's one example that they give. Now, there is some evidence to show that. The idea is we've got, also remember that part of this, again, like diabetes, part of this is environmental. Today, if I continue to gain weight, if I continue not to take care of myself, I will develop diabetes. Why? Because I have a genetic predisposition. So the twin studies similarly show that for addiction, whether it's alcohol use, most of the work was done in alcohol use disorders, that you have a genetic predisposition. So that is a more vulnerable population. Identifying that population, just like cancer. I have a friend who's she had radical mastectomy and reconstruction because she is in her 30s, but had a family history, has a very serious family history of breast cancer. So one would have said, well, the genetic and that's why she had screening and whatever else, and she's well now. But my point is, we forget that there is a genetic contribution to these illnesses as well. What we can control are the environmental pieces. And the diabetes and the heart disease analogies are, so make sure your cholesterol levels and your nutrition and your exercise, etc. Those are things we can control. And so the connectedness that people feel, help in the sort of environmental case, if you like. But you have this genetic loading. That's something outside your control. So.
Thank you so much for your talk.
Sure.
I'm interested in, you're talking a lot about measuring, so you're talking about a condition that exists. Mm-hmm. And you're also said that opioids are helpful, which they are in a crisis situation.
Yes.
Wouldn't it be beneficial, though, when you introduce an opioid to somebody, that you also introduce alternate ways of coping with that, such as yoga and meditation, so that they don't have to, they have something to go to after they are weaned off of the opioids?
Yes, I completely agree. The situations that I was talking about is accidental emergency, the ER, post-op, etc. Yoga is not going to help that. On those acute situations, right, you need a short-term relief, whether it's opioids or not. And I shouted out for opioids because they have been so effective. And that's been the problem, that their addictive potential sort of is marred by the fact that they have been so effective in the past, and then people get hooked. But it's there are several other analgesics of various types that are there and now being developed, so that they would be able to, people can then see, so, for our patients, we give them a card so that they can go, if they are ever going to an ER, they would give that card to say, do not give me opioids, because that's the first thing that people give for pain in ER.
That we're really trying to do is to prevent the lifestyle that goes into that abuse of that opioid or alcohol also. I mean, it's the same thing. We need to retrain people so that they're making better lifestyle choices.
Yeah, I agree. And to what extent is your, one glass of wine in the evening that helps you to sleep, perhaps, or you enjoy it? When does that use get to abuse?
Well, there's boundary issues too, but I mean, the other issue that I think seems to be interesting from my point of view is the resistance. So how do you handle the resistance if people are functioning, and you're saying a lot of people are functioning
Yes,
with
they are functioning.
these problems, and I know there's a lot of functioning alcoholics as
Yes.
well, then how do you get them to accept that they need to make changes in
we,
their
we
life?
use a technique known as motivational interviewing. It's a very well developed technique that pushes people into the readiness to change era. You are telling people, suppose I say, well, I'm doing well, there's no problem. I show them that their liver enzymes are elevated, though they're working fine. If you carry on like this, you are going to develop liver failure at some point. The other thing is, what is the effect this has on your family? That you isolate yourself and you're drinking. So, but I'm going to work, I'm earning stuff for my, earning a livelihood for my family. I think there are techniques in motivational interviewing that one would use to look at this readiness to change. Ultimately, if people don't want help, you can't do anything.
Exactly.
If your blood sugar is sky high and you don't want to do anything about it, ultimately you're responsible. But we have techniques to tell them, and the same thing applies to diabetes or heart disease. So that's why I said this readiness to change is a really important scale that we can use along with motivational interviewing to make people aware that this is the issue.
Thank you.
Okay. All right. Well, thank you very much.